This is Kevin Hardy. I'm with Muir, the Director of Better Value Healthcare at the APAC conference in Melbourne on the 3rd of September. Muir and I are going to be talking about leadership and where it goes in the future. So welcome, Muir.
Thank you.
Thank you very much indeed. There's a strong push for leaders around the world in health. If we don't know what the system of the future will look like, how do we know what leaders we need?
Well, the people who are leaders should design the system. I mean, the job, the future is like Sydney Harbour Bridge. Someone's got to design it. And for me, the definition of leadership, as distinct from management, is the leadership have to design what the future is going to be like. It may not be like where you start off,
Sure.
but it's up to the leadership. If you're not designing the future, you're not part of leadership.
Okay. And if we're spending so much time and talking so much about leadership, are we in the process of forgetting about that solid core group of managers who run the business on a day-to-day basis?
Yes, I think we've probably gone over the top now in leadership. And of course, it's I've got a glossary of healthcare, and there's no word with more examples of leadership. In fact, some people say it can't be defined because there's so many different definitions. The most useful definition, I think, that's emerged from my study of the definitions is leaders shape culture and managers work within the culture. I do think we're focusing too much on leadership and not enough on management and that other thing, administration. When I started in the NHS, they said the NHS was over-administered and under-managed.
Yep.
I now think it's over-led, over-managed and under-administered. You try to get a contract sorted out or something like that.
So how to sort the balance?
Yeah, you have to think all the time about leadership, management and administration. And administration, for example, has vanished off the radar. But I think you will agree, having been around a fair period of time like me, that it's not as well administered. And that gets in the way of the plans of leaders and the work of managers.
Absolutely, and you're right, administering these systems, and these are big systems, and that part of it is lost.
Yes.
So you talk about the tidal wave of change, and Maureen Bisignano talks about the velocity of change. Mm-hmm. What do you think the new paradigm is for health organisations?
Well, I'm seeing from my study of the literature, I keep about 30 journals under my eye and work in various countries. I see 5 things emerging. One is a move on from effectiveness, safety and quality to value, outcomes related to costs. The second is a move from giving better care to the patients we see to giving care to all the people in the population, including the ones you don't see, for example, by delivering a knowledge service to people. The third is a shift from competitive bureaucracies to systems, collaborative systems. The fourth, I hope, is a move from structural reorganisation to culture change. Certainly the culture word's used much more, but it's awfully tempting to change the structure and feel you're doing something. And the fifth is, and this may still be a hope, but I think it's a necessity for the clinicians to take responsibility for the stewardship of resources. And now when I'm working with groups, I ban the word manager actually, because the word manager allows the clinicians to hate the managers. And so we use the phrase people who manage. And some clinicians, I don't manage. I say, well, you've got a team. And even if you don't have a team, I say you're ordering tests, you're managing.
And it allows people to opt out and they can stereotype each other.
Even worse than opting out, it allows them to attack their clinical colleagues who've gone to the dark side, is the great phrase in England.
Well, everywhere really. People are thin on the ground, and clients talk regularly about, there's not a lot of depth available in terms of executive talent. What are the key things to develop these people? How do we put in place, what do we put in place for a rapid system of development, if you like? Because we have gone through stages where we've done 3-year turnarounds. People have come in, restructured, as you said, haven't necessarily dealt with the culture issues, and then have left it for someone else to somehow or other make it work. So I've probably made comment and asked a question, but I guess my question is, how do we prepare people for these roles now? if we have an aging population, an aging executive workforce, how do we ready the high potentials?
I think we have to take a more age-structured way, that we have to look at people in their 30s and 40s, not thinking, well, in 10 years' time, but looking at the people at the middle levels in the organisations too. Yeah. My own view is that we need to be much more formal in our training of people. As you know, because you work in industry, if an industrial company introduces some new router or some new way of working, then everyone's got to go for training. And use the word training. We change the structure and hope people think in a different way. So what I see in the APAC region is the need for something, and I would call it sort of master's level, modular. And my estimate in most countries is there's about 400 people per million population. Many of them actually are not in formal management positions. They might be researchers, educators. And I think we do get a lot bigger numbers of people involved, but it should become mandatory, like lifting and fire and safety. So we need new ways of thinking. So I'd see the need for a major education and training initiative.
How would we identify these people? Because in Australia, people who have not had a manager or a leadership role, when a crisis occurs, these people come out and they demonstrate skill which people don't realise they have. How do we find that?
Well, I think you can you go down the hierarchy a bit. So in the average hospital, there's about 30 to 50 people. That would include the head of lab services, the head therapist, and quite a lot of doctors who say, "Well, I'm not a clinical director." You know, it's so people need to be brought in to say that you're part of the leadership. Then outside in general practice and family medicine, we're much more distributed. We need to find ways. We think there's about, in a million population, there might be 30 influential general practitioners. Many of them in no formal position at all. And that's where the map on the wall is the key thing. You know, we're all serving this population. And we're increasingly trying to get all the people to work together. And so we're not changing the structure, but we are the leadership for this population. So get the map on the wall and say, well, there's nobody from that small town. There must be somebody there. And we get them involved.
Okay. How do we connect this up internationally? How do we keep this conversation going? Who do we involve in this to get more traction and sharing?
I mean, it is difficult because you have professional networks like we don't have a college of medical administrators, so we have a faculty of medical leadership. But I think it's a thing called the World Wide Web. I mean, it's not possible to manage it. But we need to have more learning. The type of resource we are developing is not another journal, but a casebook. And see, if you go to a big company like Accenture, then everyone of a certain level is expected to put a case report in every year. So I'd be interested in starting with you, if you're interested, a casebook. So every member of your learning set does a case report every year. Just the discipline of producing something. What was the problem? Why did we decide to tackle it now and not leave it to something else? It was more urgent. What did we do? Why did we do it that way? What was the result? And you'd want people to publish you'd probably give them 2 stars for something that didn't work. As 1 star for something that did work, because we learn more from other people's mistakes and our own mistakes. What lessons did we learn, and are there any documents? So, case reports, not as long as the Harvard Business Reviews, but see, in the military, you have to have an after-action report. And that's the same as you know in big companies too. So I don't think we're recording our experience.
That sounds great. Muir, thank you.
Thank you very much.
This is the first in a series of interviews with Sir Muir Gray, and we hope you can join us for the second and third one. Thank you.
Thank you.